Testing lab 9. Checking testing lavalier number 9. Lavalier number 9.
get a good feeling, yeah. Get a feeling that I never had before. No, I get a good feeling, yeah. Oh, sometimes I get a good feeling, yeah. Get a feeling that I never had before. No, I get a good feeling, yeah.
Ladies and gentlemen, at this time, please silence your cell phones and take your seats. The program will begin shortly. Please welcome Johanna Derlega, Senior Vice President of National Journal.
Good morning. I'm delighted to welcome you to National Journal's forum, Mental Health Reform, Improving Access to Care and Reducing Incarceration, made possible by Janssen Pharmaceuticals. At this time, we just remind you to silence your cell phones, but please keep them out because we encourage your engagement during the program via social media, and you can use the hashtag #NJMentalHealth. For the audience Q&A portion of the event, there are microphones on stands around the room, and just please state your name and organization if you have a question. And you can also submit your question at any time during the program via Twitter, and you can use the hashtag #AskNJ. Finally, if you haven't already, we encourage you to download the National Journal Live mobile app. It includes the event schedule as well as information about today's speakers and underwriter, your fellow attendees, and it also includes a survey. And we would love for you to fill that out so that we can continue to improve our events. This morning, we will have a robust discussion about mental health reform. As many suffering from serious mental illness face challenges getting access to care, which can result to homelessness and even incarceration. At both the state and federal levels, there is recognition that lack of effective mental health care is a public health issue and a cost driver. As several mental health reform bills await their fate in Congress, our conversation will focus on what policy changes are needed and how we can improve access to mental health services. At today's event, we will hear from Representative Tim Murphy and Senator Chris Murphy. They will each deliver remarks and then sit down for a moderated discussion with Lauren Fox, who is National Journal staff correspondent. We will conclude the program with a moderated panel of experts in the mental health arena. But now I would like to invite Dr. Elizabeth Fowler, Vice President for Global Health Policy at Johnson & Johnson, to the podium.
Thanks, Johanna. Thank you all for joining us to be part of this really important conversation about mental health reform and policies that can improve outcomes for patients and society at large. The Janssen Pharmaceuticals companies of Johnson & Johnson are proud to underwrite this event, bringing together leaders and stakeholders from across the policy, advocacy, and criminal justice communities. For too long, we've set the bar too low on how we support those living with mental illness. Globally, mental illness costs society more than cancer, diabetes, and chronic respiratory disease combined. We're encouraged about all the efforts we see underway to change this at the federal, state, and local level. We can and should set the bar higher. Enhanced collaboration between the mental health and criminal justice systems is critical to improving the health outcomes of those living with mental illness and reducing the inefficiencies and costly nature of recidivism. Opportunities exist to reform the mental health and criminal justice systems, and innovative support programs can assist in transitions of care. We are really looking forward to today's discussion of some of these promising solutions, including diversion of individuals for whom it is appropriate away from the criminal justice system, care continuity during incarceration, and reentry programs that better connect individuals to community resources when they come out of institutions. Thank you again for joining us. We're really pleased that you're here, and we're really pleased to be part of this important discussion on an important topic that affects us all.
Please welcome the Honorable Tim Murphy, co-chair of the Congressional Mental Health Caucus.
Good morning. Great to be with you. Thank you for being here on an issue of such critical importance to our nation. Last night when I was sitting on the balcony of the Capitol, I looked at the beautiful sunset and the twilight sky and the clouds, their crimson, their gold, their grays against this beautiful pale blue sky darkening. And then I glanced over to see the House Office Building and the flags lowered to half-staff. I was reminded why, during this week, which is Mental Illness Treatment Week, that once again we are mourning the loss of so many citizens who have a death that didn't have to happen. This has been the bloody summer of 2015, when many high-profile events occurred in Dallas and Houston and Tennessee and Virginia and Oregon. The list goes on and on. And although these are the incidents that get the headlines, it is a tiny fraction of the tragedies that occur in the area of mental illness that is untreated. We actually make it the most difficult for those who have the most difficulty with serious mental illness that is untreated, undertreated, or mistreated. Back in the 1950s, when we had 500,000 hospital beds, now we have 40,000. And what we have done is we needed to close those asylums of yesteryear because they were bad places in many ways. We were supposed to open up community health centers. We were supposed to have providers. You know, the last bill that President Kennedy signed before he was assassinated was dealing with changing the mental health system in America. And here it is, half a century later, and actually I believe things have gotten worse. Despite the knowledge we have in science, last summer, identifying 108 genetic markers of serious mental illness such as schizophrenia and bipolar, despite having more effective psychotherapy treatments such as cognitive behavioral therapy, despite breakthroughs in medications, we have federal policies that are quite frankly abusive and neglectful towards people with serious mental illness. They're anti-psychiatry, anti-psychology, anti-patient, anti-family. What is worse is that it is made the most harmful for those who are minorities and low income. And I want to lay that out and why we need to change this. When we closed those asylums, as I say we needed to, we ended up reducing the number of psychiatric hospital beds, but where did they go? Well, some got better with treatment, some had community services, that is good. We want them to have healthful and productive lives. But for so many, they traded the hospital bed for the prison cell, the homeless shelter, the emergency room, and the morgue. Not only this year will we have somewhere between 1,200 and 1,500 homicides by someone with serious mental illness untreated, we will have thousands and thousands and thousands more who are mentally ill, who are victims of crime and rape and assault. We will have 41,000 deaths by suicide, 1.2 million suicide attempts that were bad enough to seek medical help, 43,000 drug overdose deaths, and the list goes on and on. But the ones that grab our headlines are the ones that tell us what we need to do. In my bill, the Helping Families with Mental Health Crisis Act, H.R. 2646, we address these directly and comprehensively. The first and most comprehensive bill to deal with serious mental illness in America. We have to do that because the key federal agencies such as SAMHSA, Substance Abuse and Mental Health Service Administration, has actually been neglecting and harmful. They have taken millions of dollars in taxpayer money to do frivolous, silly, and abusive grants. Yes, they have. They fund such things as over a $400,000 website to have sing-along songs for children. They recommend drink a fruit smoothie if you're stressed. Yes, they do. And they have workshops where they tell people to get off their medication, to be in touch with their inner animal. Last winter, they had a website that tell people in Boston how to deal with their snow anxiety. And 2 days ago, the Washington Post released a story that they have sent money to an agency, a PR agency, to tell reporters they'll give $175 to the charity of their choice if they write a nice story. When an agency is reduced to that kind of bribery to the media, to say, please tell a nice story about us, because 2 GAO reports said that SAMHSA is not doing its job. There's 112 federal agencies that are supposed to be doing services for the seriously mentally ill. SAMHSA is the agency that's supposed to coordinate them. The GAO report said they haven't even met since 2009. And despite the director of SAMHSA coming and talk to us about it, she said, oh, we're going to start meeting now. When we asked about this website for children's sing-along, she says, oh, it's for prevention. We're going to look into that. We still are waiting to see the results of that. When we said, why did you spend $22,500 on a painting hanging in your office of 2 people sitting on a rock surrounded by other people? It was for mental health awareness. Here's what I'm aware of. It's a waste of money. It is a waste of our approach. And that's the way our country operates, and that's why that agency must change. That's why we say now we're going to elevate this to have an Assistant Secretary of Mental Health and Substance Abuse. No more frivolous workshops on stopping to take your medication or employees from SAMHSA marching in a circle singing songs. $80,000 on that. No more of that. Can you imagine what communities could have done if they would have had this money to treat mental health? In their 40,000-word statement of what they do, they don't even mention the word schizophrenia and bipolar. They don't even have a psychiatrist on staff. The ones they have quit because they're more concerned about talking about people's rights to refuse treatment instead of people's right to be well. When I hear the judges and police officers say, I can't do anything with these folks because it's not illegal to be crazy, I say, what about their rights to be treated? If someone was walking the streets with Alzheimer's disease, delusional, not aware of who they are, we wouldn't say, grandma has the right to have Alzheimer's. If someone had a stroke and was not aware they had the problem, we wouldn't say, well, they have a right to be stroked, nothing you can do about it. If someone was passed down the street from a heart attack, you wouldn't say, well, they have a right to have a heart attack, there's nothing we can do about it. But that's precisely what we do with mental health in America. Policies of this federal government are abusive and neglectful towards them, particularly minorities and the poor. When Medicaid has a rule that says you can't see two doctors in the same day, now if you have private insurance, you can. If you have Medicaid, you can't. That's neglectful towards the poor. When Medicaid has a policy that says you can't have more than 16 hospital beds, that's neglectful towards the poor. What we need to do is address the needs of persons and get them to see the people they need to see. When we have a shortage of child and adolescent psychiatrists, we only have 9,000, we need 30,000. And at a time when serious mental illness emerges by age 14 and 50% of the cases, 75% by age 24. But we don't have enough. We need to have incentives to get more psychiatrists, clinical psychologists, clinical social workers. We need more peer support counselors, people who've been through this. And we need a system like Mental Health America has to say, we're going to work on certifying and getting people the training they need so they can be out there. When you have agency after agency that has to struggle to get dollars to make sure they have the wraparound services, to see the waste in Washington, D.C., quite frankly, every taxpayer in America should be disgusted. And every family that's burying someone from suicide or homicide, or see someone else go off to jail and they see the frivolous and silly things our federal government spends money on, people should be outraged. And I am. And what we're going to do, once again, is have moments of silence in Congress as we mourn the deaths of these people who should not have died because someone should have been in treatment. And when I say America wake up, Congress wake up, we don't need more moments of silence, we need moments of action. We need moments of shouting out, enough is enough. Mental illness is a brain illness. It is not, according to some of the agencies that SAMHSA funds and then sends their minions out to attack this bill, it is not a difference in attitude. Hallucinations and delusions are not simply non-consensus reality. It is a brain disease that must be treated as such. My bill, in addition to having an Assistant Secretary of Mental Health and Substance Abuse to organize these 112 federal agencies, to weed out those that aren't doing a good job and to elevate those that are doing a great job, to make sure that we allow states to combine the dollars for mental health and also substance abuse because a majority of each are abusing drugs and have mental health problems. Why would we isolate them from treating together? To say we need more hospital beds. We allow the same-day doctor rule to be dropped. We make sure that for people who are in that revolving door of prison systems and mental illness, that we want states to have wraparound services for them. This is the time in this nation when we have to stop wasting our time on mourning, when we have to put agency and other groups on that sharp microscope to say, you're going to treat mental illness or you're going to get out of the way. We're going to employ the best and the brightest of people who are consumers, people who are peer support, people who are providers, and families, and allow them to be part of it. We're going to stop families from being kicked out of the treatment method. You know, I find it interesting, so often we blame families and say, why didn't the parents know? Why didn't they do anything? Well, because HIPAA laws don't allow them to participate. When people with mental illness have a much higher risk of chronic illness, either primarily because of poor nutrition and poor care, or because of the medication they take, higher risk for diabetes and cardiovascular disease, but we do not tell family members when their next appointment is, what their diagnosis is, what the treatment plan is. And yet we blame parents for not taking care of it. And what do we have from that? We have millions of Americans with serious mental illness that's untreated on that bumpy, slow-motion road to death. That is tragic. That is third world, folks. That is embarrassing. As the only person in Congress who is a mental health provider currently, I am determined to change this system, to wake up Congress and wake up America to say there are answers to this, but not the answer of continuing to do what we do again. I want the time to be that while we have the twilight of one sun setting of the day, of the way we treat serious mental illness now, I want Americans, the millions of American families, and the millions of Americans suffering from serious mental illness to look forward to that bright new dawn where we will begin to treat mental illness as an illness, effectively with evidence-based care, and make a difference in their lives. And that's why today is Helping Families in Mental Health Crisis Day in Washington, D.C., where hundreds of families are here in Washington to talk to members of Congress. And that during this week, a Mental Illness Treatment Week, people are speaking out to their members of Congress. Over 40 newspapers have published editorials in support of this. We have over 133 co-sponsors. But now it's also time to have leadership call this bill up for a vote. Let Congress, who represents the people, vote on this. And let's provide hope for those people who have been suffering in silence in the shadows for far too long. Thank you very much.
Please welcome Lauren Fox, staff correspondent at National Journal.
Thank you for joining us. I wanted to start out with, because you mentioned in your speech you are the only current mental health provider in Congress. When did you first start to realize that there were gaps in the system, that there were issues with getting your clients the help that they needed?
Actually, when I first started doing my first internships in graduate school in the 1970s, when community health centers were just beginning to emerge, I found that here were things that I was trained on that I was not allowed to do. That I found that said, well, the law doesn't allow you to do that. You can't see people, you can't work on those things. And so it was a matter of recognizing even then the barriers we had. It got even worse, however, as chairman of the Oversight and Investigation Subcommittee. After the shootings at Sandy Hook Elementary School, when we first started having our hearings, and we heard family after family and providers and consumers talking about the difficulties they had with getting care. That's when it became very clear that much of this was federal policies that got in the way.
I want to talk about this in the context of shootings and gun deaths. We often talk about mental health after a gun tragedy, and I guess I want you to sort of address why the two get interlinked and whether or not you think that might be a mistake in the way that we talk about these issues.
Well, they do get interlinked because those are the cases that get people's attention. But we have to be paying attention to what's in their minds, not what's in their hands. Because if we miss that, then we're once again going to fail to address the comprehensive reforms we need in mental health treatment. No other area of medicine is controlled by lawyers and by Congress the way that mental health is, and restricted, and it prevents people from getting the care that they need. So when we look at the suicide deaths and the tens of thousands of people that die every year from jumping in front of a car, from driving a car off a bridge, from jumping off a bridge, from poisoning themselves, from drug overdoses, from asphyxiation, we don't say we need to talk about ropes and bridges and cars. That we would understand how that's not what we need to be doing, and how that's diminishing our focus we need to have on helping people with serious mental illness. We have set those 4 million people aside and trying to ignore them and treat them with denial and diversion in our thoughts, and that's not appropriate. And as a mental health provider, I cannot let that happen. It is critically important that we have the right services for them to get better.
Do you think that discussions after shootings help give your bill a little bit more momentum as people start talking about what are the real solutions here? If it's not something on guns, maybe it's something on mental health.
I hope so. I mean, we need to recognize that most people with mental illness are not violent. Of the 60 million Americans, look, all of us experience some level of transient concerns and sometimes in our life, and we get better. What happens is if we recognize people with serious mental illness not in treatment are 15 times more likely to be violent than someone who is in treatment. And that a person who is seriously mentally ill is 10 times more likely to be in jail than in a hospital. And that getting services for them is extremely difficult. That is what I hope that this provokes us to have a discussion on. Not to say if we treat the mentally ill, all violence will go away, because it won't. We need other services for that, to deal with that issue. But at least among this group, we know that ignoring them has been a harmful process, And I hope that if anything meaningful can come out of this for the families who are suffering for the rest of their lives because they lost a loved one, at least to know that perhaps this motivated Congress to finally get up and do something.
I want to talk about the families of mentally ill patients and people who are trying to get their family members help. Obviously, there has been a shortage of hospital beds for individuals. I guess I'm curious, how does your bill address that? And do you see a promise for ensuring that families get the help for their loved ones that they need?
Well, what we do is we lift the limit on hospital beds from 16-bed cap to say as long as the average length of stay is 30 days or less. This actually can save money because it covers about 98% of people. And when we look at the difference, for example, between psychiatric hospitals that have this versus having someone in a general hospital bed where they may not have the full services, in the general hospital they actually may spend twice as much time with fewer services versus one that is focused specialty hospital with that. And actually, in many of those cases, the average length of stay is under a week because they can target services right away. But additional to that, there must be wraparound services afterwards. And this is where Medicaid pays for some of these things, which is extremely helpful. And agencies that say they're going to make sure that if someone's moving out, they have all those services secured for them: housing, supportive education, supportive job placement, making sure that they have their counseling and other aspects there too. But more than having an agency do that, involve the family to whatever extent we can, because these are many times loving and caring parents who someone has emerged with mental illness for genetic reasons, for other reasons, whatever that is. And we have to stop telling family members, you're cut out of the equation here.
And your bill obviously makes some changes to HIPAA laws to ensure that families can be more involved.
Right. It's two small changes. One is already permitted. Doctors are allowed to listen to a family member talk to them. But many times lawyers tell the doctors don't do that because they're going to get in trouble. But they really are allowed to listen. But that only works if a family member or a friend or some trusted caregiver comes and says such things as, this is John Doe, he's my friend, or he's my son. You need to know, here's the name of his treating psychologist, here's a psychiatrist, here's the medications he's on. Don't try this medication, it's been harmful before, do this. So that information is vital. For a mental health professional, history is vital. It's like an x-ray is to an orthopedic surgeon. If you say, try and diagnose a broken leg, but you're not allowed to look at an x-ray, tell a neurosurgeon, tell us if there's a tumor there, but you can't look at an MRI, we would never do that. History is vital. But the second part that is needed is in those circumstances, and it's a very narrow keyhole we have here, but in those circumstances where the consumer has diminished capacity, can become gravely disabled in absence of treatment, may have other medical complications such as heart disease, lung disease, diabetes, infectious disease, the doctor's got to make a decision next. Is this a trusted caregiver? Not a stranger, but someone who really is a trusted caregiver. The doctor in that circumstance can give out limited but vital information: the diagnosis, the treatment plan, the doctor's name, the time and place of the next appointment, and the medication list. It's also forbidden in our bill to give any therapy information. That will remain totally confidential. But at least if that family member or that friend or that trusted caregiver is going to assist that person to go on the next appointment, that will help them. And it can save a lot of lives, because otherwise you end up with the continuing issue that seriously mentally ill people tend to die 25 years sooner than the rest of the population.
I want to discuss sort of the intersection of criminal justice and mental health. Roughly 20% of individuals serving in prisons have some kind of mental illness. And what can we do to ensure that our jails do not become receptacles for the mentally ill? What can we do to expand care so that it's not sort of the last resort?
Sure. Well, actually, some estimates put that much higher. It's more like 50 or 60%. Far more in county and city jails. State penitentiaries are pretty high. Federal penitentiaries under 20%. But the point is, if that is a major contributor to what has happened, several things need to happen. If you do prevention early on in someone's life, you make a world of difference for them. But not frivolous prevention like happy sing-along songs on a website. I mean targeting a risk group, which is called secondary prevention. This is the high-risk group. Or tertiary prevention, first signs have shown up. You can use programs such as one called Response After Initial Schizophrenic Episode, which is authorized in my bill, which has been very valuable. But you do these things early on, and you make sure you have enough providers, because we have a shortage, make sure there's enough places for treatment. But then if someone is caught up in this cycle, this revolving door, we want states to have some wraparound services for them. In New York, they call it assisted outpatient treatment. States have different things. 46 states have this on the books, but they don't always use it. And basically it is, if you have a history of violence, incarceration, arrests, and mental illness, and you're not engaging in treatment, and when you're not in treatment, you end up back down into this abyss of troubles, the judge can order you to outpatient care to stay on your medication and stay in treatment. Now, this is very important because sometimes people say, oh, you should never have involuntary commitment of any kind. And to those folks, I say, you're wrong. Because some people, noting that about 40% of people with serious mental illness are not even aware they have a problem. They're not aware their hallucinations, delusions, etc., are even in existence. So they say, I don't need help. And in some cases, it's someone who's been harmed by the system, they don't want to get help. But what happens is when the state mandates you got to get help, the state must provide that help. That's important. We want those services to be flexible because we don't want people in that revolving door. Let me tell you the alternative. A gentleman in Virginia, I think last week, 24-year-old, was arrested for about $5 worth of theft. Stole a soft drink, a candy bar from a 7-Eleven. He went into jail because there was no room in a hospital bed for him. He remained in jail for over 70 days. Filthy, naked, untreated. He died. Starved. He died. There is no way that person should have ever been put into jail. We should have had services, we should have had people who were involved with advocacy work to say, get him in treatment, to work with the state of Virginia to say, you need places to treat people, to tell Medicaid, you need to change your rules so that someone like this, who is impoverished, who is a minority, shouldn't be getting their treatment in jail or they're being ignored in jail, so they should be treatment. So it's those kind of services which we believe are vital and the more compassionate thing to do.
Are there mental health services in jails and prisons in local communities to prevent sort of, if an individual is put in jail, to prevent them from getting more traumatized as part of being
Some
in
yes,
jail?
but many are no and many are weak, if anything. We have some states who try and save money by not giving medications. We have some states that says, let's save money by shutting down our institutions, and the money is not sent to where it needs to be towards real treatment. So that is a troubling option. There was an article in the New York Times a couple months ago about Rikers Island, and they found that many of these people with serious mental illness, they would get in fights with prison guards, their inmates, they'd have new charges on them. What started off as a minor offense became an elevated offense. They would get tased, they would get put in solitary confinement. Those are terrible things. You should never do that to someone with mental illness, or quite frankly, other people too. But what happened is a person with mental illness for the same crime will tend to serve a prison sentence 4 times longer than a person without mental illness. And it's part of what we're seeing as the shame of our system when we have agencies that don't even want to address serious mental illness and want to waste money on silly things and want to waste money on bribing reporters to tell nice stories about them. This is a shameful story of what's happening here. And what we need to do with those folks, instead of saying we have to criminalize mental illness before you get help, or you have to say you're going to kill yourself or someone else to get help, why are we dealing with things at stage 4? We need to be dealing with things at an earlier stage, saving lives, saving money, being more compassionate instead of ignoring it till it gets so bad.
Is there a local program, state program that you have seen works very effectively in getting it in the ground level so that it doesn't get elevated?
Well, what I mentioned, the response after initial schizophrenic episode is very good programs, very targeted, very science-based, evidence-based. The National Child and Adolescent Traumatic Stress Network, looking at high-risk groups of adolescents, young adults who have been assaulted or traumatized in some way, very effective, very, very good. One of the GAO reports that they did on SAMHSA said they don't follow through, they don't have scientific standards. Many cases they don't have reports that come out. This wasn't me, this is GAO. And by the way, after that, we asked the director of SAMHSA, how would you score yourself on this? She said, I'd give myself 10 out of 10, perfect score. This shows you how out of touch federal agencies are. When they can't even be humble enough to say, you know what, we need to change. So that's why we're going to change it for them. That's why the people elect us to make these changes. When you have agencies that won't do that. But there are some excellent programs out there. That's the ones I say we want to see elevated. We don't need 20 homeless programs. We should have those coordinated. We need better continuity between Department of Defense and the VA when veterans. The ones I work with, for example, I'm a Navy officer. I work at Walter Reed Hospital with PTSD and traumatic brain injury patients. We need smooth continuity for them between when they're in the Army and they're in the VA. Otherwise, what do we want to see them end up in jail or homeless? That's not appropriate.
You have 133 co-sponsors on your bill.
Bipartisan.
Tell us a little bit about working across the aisle on this issue and whether or not you feel confident that the time has come in Congress to get this bill on the floor and get it passed.
The time has come, and it really is going to be not necessarily from the political insiders in Washington, D.C., because people want to protect the turf of their agencies. This is a grassroots movement across America. Of those 133 co-sponsors, there's some real dynamic people on both sides of the aisle. Some of the leaders on the Democrat side, Eddie Bernice Johnson of Dallas, Texas, Marcy Kaptur of Cleveland area, Toledo area. You have a wide range of people who are really outspoken on this. Anna Eshoo from California. The list goes on and on. On the Republican side, we have a lot of real vocal supporters too. But you know what? It's going to take American people to be picking up a pen, picking up a phone, or picking up their computer and contacting the members of Congress saying, move this bill, because we can't risk, again, 80, 90,000 people per year dying from untreated mental illness, but get them help.
I want to give the audience an opportunity. We're going to start questions in about 5 minutes, so just give you an opportunity to start lining up if you get to that point. I also want to talk about the language that we use when we talk about mental illness and sort of how this stigmatizes the issue, makes it difficult for people who don't have loved ones with mental illness or not living with mental illness, how they kind of perceive it. Is there a better way to discuss this issue? How can Congress sort of help us understand that?
Well, we do it a couple ways. One, we develop a stigma by not having services available. When you don't have enough places for people to go with mental illness, sometimes they're drop-in centers, sometimes they're peer support people you can call, sometimes they're psychiatrists, psychologists, social workers, nurse practitioners, community health centers. We don't have enough of any of those. We need those things. That helps reduce the stigma because we make it easier to get help. You know, when you look in a town and you see a breast cancer treatment center or heart treatment, man, they're beautiful, beautiful buildings. When you see a mental health clinic, it's usually hidden away somewhere, oftentimes not well funded and struggling because every year they got to spend what meager money they have to buy maybe another chair at the end of the year because they can't transfer to the next fiscal year. That's part. Part of it is elevating this up. You know, as we're looking at this Breast Cancer Month, you know, you'll see NFL teams wearing pink gloves and socks and even the referees pink wristbands. The fountain in Pittsburgh has pink dye in it, and all those are great. We bring great awareness. I mean, that's important. I have a sister who died of breast cancer last year. That's important to me personally. But then when you see a football player who wears green shoelaces to bring attention to his bipolar illness, he's fined in the NFL. I'm looking forward to the day when the NFL says, you know, this is the day where we're going to wear green in support of that rebirth of recovery from mental illness. I hope we do that. That's why I wear a green tie when I'm talking about mental health things. I want people to think of recovery and regrowth like the spring, where after this long doldrums of winter, things are sprouting anew again. I want people to have that kind of hope. And it's also going to be a matter of family members speaking out and people who are in recovery speaking out to say we can get better, but we got to have the help.
You've made a few changes to your bill since introducing it a few years ago. Most recently, one of those changes was giving an incentives to states that implement assisted outpatient treatment instead of penalizing the states that do not. How do you find the right balance when it comes to legislating mental illness to make sure people get the help that they need, but also that their civil liberties aren't infringed upon?
Well, I think one of the primary civil liberties is to make sure people have the right to get well. Somehow we've gone down this perverse road and say they should be allowed to be sick and wither away and to be homeless and die. I mean, how cruel and heartless is that? When I hear judges say, well, he's got the right to be crazy. We wouldn't say you have the right to have a heart attack and die. We wouldn't say that. You have the right to have Alzheimer's. We wouldn't say that. But we perversely assign that bigoted label to people with mental illness. With assisted outpatient treatment, many states, 46 states have it on the books. But whether or not they do it is a problem. When New York did this, the money they were saving, they actually put back into the system, so that was good. People had better access to services. But they found they reduced incarcerations by 80+%. They reduced rehospitalizations and reduced homelessness by over 70%. They found consumer satisfaction up above 90%, and they cut costs in half. That was a Duke University study and a Virginia Law Center study on the New York system. As other states and counties do this, they actually find it's more compassionate to help people who are in that revolving door of problems. We don't want to read more stories of the 100+ people who have mental illness that were involved in a police altercation and died. We want police to be able to approach folks in a calm, an organized way and say, okay, we're going to get you help. That's all going to be part of how we're going to address these issues.
I want to speak and kind of end on the question of how police officers can be trained better to interact with individuals with mental illness. A high percentage of the individuals who are killed by police officers have mental illness. How can those confrontations be de-escalated?
Well, there's something called crisis intervention training, which our bill authorizes payment on too. And this is training for police officers how to understand and identify a situation right at the onset. Many times they can tell by how the person behaves, how they're dressed, or they're homeless, et cetera, that this person needs a different point of view. And even if someone is in a threatening posture, how to de-escalate that quickly, how to talk to the person calmly, how you have police officers positioned. You have to protect the officer's safety and the family's safety, true, especially when the person is threatening. But in many cases, there's someone who may be verbally hostile or frightened or scared or paranoid or hallucinating. But there are programs out there, and we want police to get that extra training so they're not in an unsafe position, so families feel safer, but also and primarily so that individuals with mental illness is treated like a human being so that they can be safer and recover as well.
Thank you so much. Let's move on to audience Q&A at this point. Individuals who are lined up at the mics. Let's start over here on my right.
Talk in the mic so I can hear you.
Okay.
Yes, now it is.
All right. Yeah, I heard about this kind of late last night, so I haven't done my background information, but word in the trenches is that your bill is highly threatening to people who have a psychiatric diagnosis, that there are more controls being put in place and more civil liberties.
And who'd you hear that from?
Oh, several people.
Who? What organization?
Daphne Klein, On Our Own.
Yeah, so what happens is organizations, and many of them that actually get funding from SAMHSA, and SAMHSA put out the word to make sure that...
SAMHSA didn't say anything about this.
No, they do, because they fund a lot of these organizations, and they say, hey, make sure you speak out because you might lose your funding. We're not taking away funding from people. And we are actually protecting people's rights to be well. Well, let me finish.
Okay.
So what happens here is people have the right to get better. There's nothing in our bill that takes away rights. There's nothing in a bill that mandates involuntary commitment. Zero. Although I hear people say that. I heard one organization told their audience that our bill has something that says if a police officer stops you for a traffic accident, they can force you to take medication. That is simply not true. So they're creating a whole cloud of lies around it. That's simply not true. What we want to see, because what we say is we want more providers, we want more places for treatment, we want grants that have accountability to them, we want innovation grants, we want demonstration grants, we don't want money to be bottled up in Washington, we want it to go out there, we want more efficiency and effectiveness in this to get people care. So I understand there's a lot of people within the Beltway system that don't want to see the system change, but here's the thing. While NIH, for example, has worked so hard, we've put a lot of federal dollars into treatment for so many other things, we've seen a decrease in death rates, mortality rates, for heart disease, for cancer, for auto accidents, for AIDS, declining rates. At the same time, we've seen increases in suicide deaths going up, drug overdose deaths going up, crimes, more people in prisons, more people homeless. Those statistics are telling us the system is failing those it's supposed to help. So while I want to make sure that there's nothing in a bill that takes away people's rights, but I understand people don't want to change. The current system is failing. And, I'll tell you what, you want to talk about people's rights? Go to the parents whose children died at Sandy Hook. I've got their photos sitting in my office from the time those parents sat in my office. Every day I look at those kids' faces. Where's their rights? Where's the rights of the students who just died in Oregon? Where's their rights to have a hopeful future? How about that police officer in Houston, Texas a couple weeks ago was gunned down, simply getting gasoline from someone who had serious mental illness that was untreated? Case after case after case of this. Where's the rights of those 41,000 people who died a suicide death? Where's their rights? Are we to say, well, if you're crazy, it's okay if you kill yourself? I say no. And any of these organizations that want to create this atmosphere of lies to protect their status quo, no. And what's worse is they prey upon people with mental illness and families by frightening them with falsehoods. That is unethical for them to do that. And so whatever information you have, I'd be glad to show you. But here's what I want you to do. You show me the word or the line in our bill, and I'll change it. But they can't do that because it's not there.
Thank you so much. Let's move over to the left side here.
Thank you very much. Am I on? Thank you.
Yes, you are.
Good morning, ladies and gentlemen. My name is Anthony Hernandez. I'm from Los Angeles. I traveled over here red-eyed just to be here to represent over 1,500 families globally on this very issue of how this broken mental health system in our nation has destroyed all of our families. Our children are dying, our kids are being incarcerated, and after incarceration, they're being put in state mental hospitals. They're being taken away from us. I like to do this where I'm talking in front of individuals. How many of us in here actually have been experienced and had a tragedy of mental illness amongst them and close to their family? Let's see your raise of hands, please. So then we consider you all part of our family as well. A couple of months ago, we were here in May, invited by the congressman and the Treatment Advocacy Center to speak our voices and share our stories. Our story came out in the Los Angeles Times. Our son was hospitalized 8 times in 5150, 8 times, And on the 9th time after we had the police there the day before, we begged them to take our son again. They denied us. They left him there with us. And the next day he woke up because God told him to stab and kill his mother and father. And this is what he tried to do. And he also killed our dog. So now he was faced with double attempted murder and cruelty to animals. And now he's serving a life sentence in Patton State Hospital in San Bernardino. He's only 20 years old. He's my baby.
Mr. Hernandez, so along those lines, and going with the question we just had about protecting rights, what rights does he have in jail? Zero.
He don't have any rights,
What
sir.
rights does he have now locked up after that? Zero.
Right.
And that's what I mean. The more compassionate thing to do is get people help. You were probably aware, we've had this discussion before, there was a case in the state of Maine where one of the protection advocacy groups were there. And when a gentleman was asked if he was going to harm himself or someone else, the advocacy person told him, make sure you say no. And he said no. They released him from jail, and when he went home, and hallucinating and thinking his mother was part of Al-Qaeda, took an axe and chopped her to pieces. What rights did she have? So but primarily, he had the right to get better. He had the right to better treatment. And thank God you and your wife lived, and thank God you're there to help your son in the future. And I hope things turn around for him.
Let me share something else with you. What's strange is that now that he's in Patton, he has a psychologist, a psychiatrist, a social worker, a psych tech, all to his disposal on a 24-hour basis. This is what he needed to have on the outside. But he had to break the law in order to get what he has now. So this bill that the doctor is trying to pass, we're all sitting every day waiting to hear Congress move forward with this necessity in our nation. And guess what? The rest of the world is watching us to take leadership, as we do in many other things, to fix our problem that's such an old, ancient problem. It's been around forever. It's time. The momentum is here. Our movement is here. We're not going anywhere. We're 1,500 strong and growing. We're only 2 months old. And we're not going anywhere until this bill's passed.
Thank you.
Thank you.
Thank you, Mr. Hernandez. I want to take a question from Twitter. We have a question here that says, for the American health system, what barriers are there and how can we better bridge minority health disparities?
Well, some of the biggest barriers are you can't see two doctors on the same day, not enough hospital beds. Services for minorities are limited. We don't have enough minority providers in psychiatry, psychology, social work. Part of our bill also makes sure that there's minority fellowships is authorized, so people are out there having access to treatment. And again, the issue for many minorities, they tend to get their services in prison. And so you have generation after generation of people in jail. We need to have easy access for them with quality, visible services early on and continue on in their life.
Thank you. We'll take a question from this side again.
Thank you. Representative Murphy, I'm Stuart Gordon with the National Association of State Mental Health Program Directors. We want to express our appreciation to both you and to Senators Murphy and Cassidy on the other side for all the work that all of you are doing on the mental health issue. The SAMHSA administrator who responded with a 10 out of 10 score after the GAO report has been gone for about 2 months. And I understand you've had an opportunity to sit down with the new SAMHSA administrator to talk about your concerns, and that she's told you about some of the things they're doing to strengthen the grant monitoring system and the...
Really, when did that meeting happen? When is that going to happen? I mean, no. We had asked SAMHSA for a document also commenting on this. We're still waiting months later to tell us about some of the programs, some of the messes they have. I would love to have an open conversation, but it has to start with this. They've got to change. They cannot continue to have this belief that serious mental illness doesn't exist. They can have frivolous prevention programs and spend whatever money they have unaccounted for. That has to fundamentally change so it gets out there. I welcome conversations with any of these federal agencies because it has to change. The American people are demanding it. To have this kind of insensitivity and unresponsiveness has got to change. And what happens here is, among providers like you and others, the most compassionate and caring people I've ever met. I spent 40 years in this career. People who, let's face it, you're not going to get rich with what you do. You do it because you love what you do, because you love the people you're working with, and because you're always struggling to find them help. That kind of altruism is extremely valuable. Well, federal agencies ought to pay attention to that. Get outside the beltway and hear from people what we need to be doing as providers.
Thank you. We just have about a minute left, so quick question from this side.
Unfortunately, it's kind of loaded. Good morning, Mr. Murphy. Thank you. Neat information. Jessica Kong, Executive Director of June E. Associates here in Washington, D.C. Sort of a tongue twister, so I'm just going to literally read it off. How does your bill address the need for cross-cultural staff to ensure culturally competent care in compliance with the national culturally and linguistically appropriate service standards in legislation?
How does it, so it's already required?
Different states have passed, I believe, 8. It is mandated.
So are you saying that that's already required?
That's what I'm trying to explain.
Okay.
Across, I think it's 8 states, it is mandated. I think 13 it's on the table, and a couple have vetoed it.
What states individually do is up to them, but certainly along those lines, we recognize that's valuable. And are you saying that that's a federal regulation?
I'm not familiar with the process. I'm just learning.
Okay. Because to the extent that those are out there, what we're doing is we're trying to pick up the slack for a lot of failed federal agencies that haven't paid attention to that. I think that's extremely valuable to have that. That's why we want to make sure there's more access for providers who are minority members and being part of communities and being out there. As we have made major changes from our first draft of this bill, 3717, to the current one, 2646, and we're working on other things there too. We recognize that's a valuable part of the necessary change, that people do have that cross-cultural sensitivity to help them take down those barriers. We want to do that. So if you have other wording on language, help us with that. I'm glad to look at that.
Absolutely.
Thank you so much. I really appreciate your time, Congressman. We really appreciate for being here and really engaging in a beneficial conversation.
Thank you. I hope America will speak out. All right,
thank you so much for your time. I really appreciate it.
Please welcome the Honorable Chris Murphy, member of the U.S. Senate Committee on Health, Education, Labor, and Pensions.
Well, thank you very much to National Journal, to Janssen Pharmaceuticals for having me here today. I got to listen to a bit of my long-lost cousin Tim Murphy's presentation. I read once a 1,000-page history of our homeland, Ireland. And I kept on waiting for the Murphys to show up in this history to talk about all their great deeds. And I flipped finally to the index and found out that in a 1,000-page history of Ireland, there's only one single Murphy that shows up anywhere in it. And so we like to think that we waited to do our good deeds until we came to America. But it's great to be here with Tim, who's been a wonderful partner in this effort. And thank you to all of you for a really fantastic turnout this morning. We feel, both in the House, but particularly in the Senate, given that we've had a little bit later start on taking this issue seriously, that there is momentum in a new way behind attacking the behavioral health crisis in this country. And I'll maybe finish my remarks by talking a little bit about the political context and some of the thorny questions about how to talk about mental health in the context of these mass shootings. But what we know is that this has been a crisis for a very, very long time. And it's nothing new for families who have been dealing with it for a long, long time as well. For all of us, this is a personal issue. For Tim, this is a personal issue because it's been his livelihood, his profession. For many of the rest of us, this is personal because we've watched close family members try to navigate a system that simply doesn't work. I often say that my family has a long, proud history of mental illness. And I say that because we talk about it in my family, not unlike we talk about our cuts and bruises and scrapes and our broken bones and our predisposition to heart disease. We talk about the fact that we also have a history of behavioral health in our family. And we've been lucky enough to have the resources and the capacity to navigate through a very complex system. But we know in my family that others don't. And that's really what this piece of legislation is about, to finally give answers to these families who feel like they hit brick wall after brick wall. When we set up the community mental health system in the 1960s, it was one of President Kennedy's signature pieces of legislation. It was called a bold new approach at the time, and it was. This was our effort to close down what were at that time called insane asylums and move people with mental illness out of institutions and into the community. And it was the right thing to do. But over the intervening 50 years, we've encountered two major problems with that bold new approach. The first is that we never properly resourced the community care necessary to properly care for the people that left these institutions. And as you know, what happened is that many of them didn't get served and died. Others got reinstitutionalized in emergency rooms or prisons. We just didn't keep that promise, as we often say in Connecticut, in the wake of that community mental health reform. But the second thing that happened is that by virtue of our concern for setting up a new community mental health system, we ended up compartmentalizing mental health and behavioral health walled away from the rest of our healthcare system. And we all see it today. We have community healthcare clinics that we're proud of, that we invest in. But as we increasingly understand how the entirety of the body works together, and frankly, as we increasingly understand that by treating mental illness in a wholly different physical space, with a wholly different reimbursement system, with a wholly different set of insurance rules, we really perpetuate that stigma. And so the legislation that we have introduced, myself and Senator Cassidy in the Senate, and Tim Murphy and Eddie Bernice Johnson and others, it certainly is about building new capacity. We've got some major Medicaid reforms here, which is going to attack the diminution of 4,000 inpatient mental health beds since 2007. That's going to allow for more people to be able to see primary care and behavioral health clinicians on the same day. But it's also about trying to bring these two systems together. I'm particularly proud of a program in our bill, the Mental Health Reform Act of 2015, that would provide grants to states to try to break down the existing regulatory barriers to the coordination of physical and mental health. What I hear about in Connecticut is that community mental health clinics and community primary care clinics want to collaborate, but because states regulate them wholly differently, they have a hard time working together, even harder time co-locating. And so our legislation really is designed not only to add capacity, but also to try to get these two systems working together. And we hope that by doing that, we're attacking this stigma, that we're not just making the system work better, but we're bringing the system together as well. But we also hope that there are other parts of our bill that attack that stigma. We take the next step in parity in the Senate bill by forcing insurance companies to disclose what all of their bureaucratic hurdles are to the guarantee of parity that we passed several years ago. We give the administration new enforcement powers to actually make real that guarantee, which has been illusory for far too many. We attack the discriminatory treatment in the way that research is done by setting up a new research organization that will specifically focus on best practices for the delivery of mental health, and to start challenging our colleagues to put money into that kind of research, just like we're putting it into other types of research at NIH and CDC. And I'll tell you, we are hopeful that there is serious momentum behind this bill in the Senate. We only introduced it right before the August break, myself and Senator Cassidy, but already we have 5 Republican co-sponsors and 5 Democratic co-sponsors. This week, we just added our new pair, Senator Capito and Senator Schumer. I think next week we will likely announce another pair. I will be honest, we are actually have a longer line right now of Republicans than we do Democrats waiting to get on this legislation, which is wonderful to have as a problem. And we feel like with a hearing scheduled in the HELP Committee later this month, the first hearing in the HELP Committee on mental health in 3 years, and that's amazing to think about, that we're poised to move this bill. As my time is up, before I sit down, let me just spend 2 minutes talking about the context of messaging here. I know that we're talking about this in a more robust way because of these shootings. But I went to the floor yesterday to challenge my colleagues to understand that the mental health system, the behavioral health system, has to be fixed because it's broken. Period. Stop. And that we shouldn't fool ourselves that we are going to cure the nation's epidemic of gun violence by fixing a broken mental health system. Why? Because the United States has a gun violence rate that is 20 times that of all of our other competitor OECD nations. And yet there's absolutely no evidence that we're spending less money on behavioral health or that we have any greater rate of mental illness in this country. There's something different about the United States, but it's not necessarily in our behavioral health system. And I don't deny that if you fix some of the gaps in our behavioral health system, it will have a downward pressure on violence. But we have to be very careful over the coming weeks and months of debate of falling into the trap which tries to define America's growing gun violence epidemic as one that is rooted in a behavioral health system. I don't mind conflating the two because I think that it will ultimately help to make our behavioral health system better. And if this is our opportunity and our moment to try to pass something, then we'd be fools not to take it. But ultimately, we're not going to fix the gun violence epidemic in this country if we don't get serious about what differentiates ourselves from other countries. This is not a forum to talk about that, but it isn't necessarily questions surrounding our behavioral health system and how we fix it. Thank you very much for having me. I look forward to the debate.
Please welcome back Lauren Fox, staff correspondent at National Journal.
Should I see this on here? Thank you so much for joining us today. I wanted to start out with the bipartisan nature of this bill, obviously a rarity in Washington, D.C. Can you take us a little bit behind the scenes of how this issue became so bipartisan, what it's been like to work with Congressman Murphy and others, Senator Cassidy and the Senate?
So I give a lot of credit to Tim. Tim's a good friend. He really set a precedent for bipartisan cooperation in the House by building this robust group of Republican and Democratic co-sponsors. And when I decided to really dive into this issue at a new level at the beginning of this year, I decided that the most likely vehicle that was ultimately going to become a law was going to be the one that had the biggest amount of bipartisan support in the House. So I went to Tim and said, listen, I don't know that I agree with everything in your bill, and I don't know that I can guarantee that I'm going to introduce a carbon copy, but let's try to do companion bills that have the same foundation with maybe some differing branches that come off of them. Bill Cassidy was very involved in Tim's bill in the House. And somebody said to me actually early on, you should go talk to Bill Cassidy about this, because he would walk into Tim Murphy's hearings with a dog-eared copy of the book Crazy, which many of you have read and is a guidepost for a lot of us who care about this issue. And so I approached him and he immediately said that he wanted to dive in along with me. We spent a long time working on the draft of the bill. It is largely a companion bill to the House measure, but we've got some things that are different, a little bit more focus on prevention, for instance, a little bit more focus on coordination. And I have been very pleasantly surprised at how fast our colleagues have signed on. We immediately rolled out the bill with myself and Senator Stabenow and Senator Franken, who on our side have really done the most work on mental health. On his side, it was him, Senator Collins, and Senator Vitter, and then we've added since then Senator Capito on their side and Senator Murkowski. I think we'll add more very quickly. And I think what this will become is a bill that has bipartisan support, but a bipartisan support that's actually sort of a cross-section of ideologies within each caucus, which I think is important as well. It's not just the moderates working with the moderates. It's really progressives, moderates, conservatives, moderates all together, and that'll be a pretty important signal to leadership.
I want to give you sort of an opportunity. You addressed this at the end of your speech just now, but we've often talked about mental health legislation in the context of the gun debate, and there always seems to be more discussion and momentum after a tragedy occurs. Does that stigmatize mental illness? Is that a concern of yours as you're working on this bill?
So I think this is an incredibly important topic, and I've talked very openly with my colleagues, especially on the Democratic side of the aisle, about how we talk about this. What we know is that there is no inherent connection between mental illness and violence, that people with mental illness are 10 times, 20 times more likely to be the victims of violence than the perpetrators of it. And we do risk perpetuating this stigma. And we see it play out in really disturbingly open and blatant ways today. Remember the Germanwings plane that went down in Europe? Remember the conversation that was openly playing out on major cable news networks after that, that someone with a history of depression shouldn't be allowed to fly a plane because somehow there's a connection between depression and a desire to take down a plane in an act of mass murder. It's ridiculous, but it shows how easy people make this connection between even between mental illness and a predilection to violence. It doesn't mean that we shouldn't forsake the opportunity that's been put in front of us to bring this bill to the floor, but it's why yesterday I went down to the floor and gave a specific speech calling out my colleagues and saying that if you really want to take on gun violence, then you have to take on the celebratory culture of guns in this country. You have to accept the fact that what makes us different from other nations is not the amount of money we spend on behavioral health. We can do much better. What makes us different is the fact that when people have a dispute in this nation, when people are dealing with internal demons, they go reach for a shotgun to try to settle their disputes. That's not what happens in other countries, and I think that it's important to add some lines of clear distinction as this debate goes forward.
I want to talk a little bit about your bill and what it does to help identify and help young people who are diagnosed with mental illness. Obviously, getting to individuals earlier can be very helpful in their treatment long term.
So we've got a very specific program in this bill which would engage and invest in early intervention. So our bill starts the program at 3 years of age, but we've actually heard a lot of feedback. I've done 11 or 12 roundtables in Connecticut, and one of the things we heard loud and clear was that we should actually move it to 0. Early intervention programs that really identify individuals who are showing those warning signs of mental illness, serious mental illness, and get them resources and get their parents resources up front. The bill continues to make down payments on things like mental health first aid, which is a program of early identification by people who are watching kids, daycare providers, teachers, social service personnel, so that we can find the kids and get them into treatment. And then again, it's just a matter of building capacity. I really believe one of the most important things in this bill is this ability to see a primary care provider and then on the same day be able to see a mental health clinician, because a lot of these kids are coming in to see pediatricians, but then when they get that referral to a behavioral health provider, either they can't find someone or the logistics of getting to them just become too big for families that have a lot of economic and social challenges. And so co-location of primary care and behavioral health, which will be made easier under this bill, I think will get a lot of kids who are already seeing their primary care physician pretty regularly into behavioral health treatment.
I also wanted to talk just a little bit more. Your bill calls for an HHS Assistant Secretary for Mental Health. Symbolically, what does that say about how it changes Americans' view of mental health issues? And also, logistically, what does a new role do? Does it create sort of organization, or are there fears that it could create more bureaucracy?
Well, so this is a subtle but maybe important point of distinction between the House and the Senate bill. We keep SAMHSA intact in our bill. We certainly think that there are ways that we can reform SAMHSA, but we don't think it's necessarily productive for it and its leadership to be eliminated. We do, though, parrot Tim's bill by setting up this new assistant secretary. And here's where we're coming from. What is frustrating is that most all of the serious conversation and debate about mental health and substance abuse is happening within SAMHSA, which is controlling a tiny portion of the federal government's spend on mental health, behavioral health, and substance abuse. Most all of the money that's being spent on that programming is happening within Medicare and Medicaid. And yet there is no one sitting next to the secretary who is thinking creatively about how you use Medicare and Medicaid in order to advance new treatment models in behavioral health. PCORI, which is the new comparative research center set up under the healthcare law, is actually doing more work in behavioral health research than they are on any other sector of research. And they said that it was unexpected to them, but they just found this sort of giant lack of research in the best behavioral health practice models and are trying to fill it. But if there's not somebody in the secretary's office who's translating what a group like PCORI is coming up with and making sure that it is infused into the way that Medicare and Medicaid work, then we're really not getting the biggest bang for our buck. SAMHSA is important, but you have to have somebody who's overseeing the big mental health spend, not just the targeted dollars that are going through SAMHSA to states.
How do we ensure that insurers are following through with the changes made in the Affordable Care Act? Is there more that can be done there to ensure parity?
Well, they're not following through. I mean, they're not. And we hear it on a daily basis that insurers have just taken this guarantee of parity, that you have to technically cover behavioral health like you cover physical health, and erect so many barriers to getting that behavioral health benefit that it just becomes meaningless often. And the stories are heartbreaking that we get. You know, one of the things I'm struck by is that when you walk into an emergency room in Connecticut and you've got a broken leg or a bleeding ulcer, you get treatment immediately, right? But if you walk in with a complex behavioral health issue, and let me correct that, when you walk in at night. When you walk in at night with a physical illness, you get immediately treated. When you walk in at night with a behavioral health diagnosis, you sit in the hospital until 8 or 9 the next morning. Nobody touches you, nobody treats you, nobody evaluates you. You know why? Because they won't touch you until they know that they can get somebody on the phone at an insurance company to give you the prior authorization for treatment. And so they warehouse you overnight. Physical health doesn't require that prior authorization. You can diagnose and treat immediately. But for some reason, the brain is different. For some reason, the brain requires prior authorization. What we need to do is what this bill does, which sheds a light on the processes that these insurance companies use to try to deny treatment, and then give new enforcement mechanisms to the federal government to go after companies that are violating the law by essentially doing an end around with these bureaucratic hurdles.
I want to give the audience a chance to line up for questions. Those are going to start in about 3 minutes. Are there local or state programs that you view as leaders on this issue? If you've started digging in, have you discovered things that you thought to yourself, wow, this is a great idea, this is something we should be doing on the federal level?
Sure, and this bill, I think both our bills in the House and the Senate are infused with work that we've learned from state governments, programming specifically designed to do early interventions on schizophrenia. For instance, our state programs that are now funded in this bill. We have a wonderful but simple program in Connecticut, and it's in a couple other states as well, that invests in telemedicine that allows for primary care physicians who encounter a patient with a complex behavioral health diagnosis to call up immediately a behavioral health clinician who will do an immediate in-person phone consult while the patient is in the office. So rather than have to send them across town to the behavioral health clinic, you can get an immediate conversation on the phone. We're doing that in Connecticut, and it's getting rave reviews and really good outcomes. So we pilot program that in this legislation as well. So, we really do believe that a lot of the innovation starts at the state level in the House and the Senate bill. Both, I think, involve a number of programs that come from the grassroots.
Even though 1 in 5 adults is diagnosed with some kind of mental illness each year, the number of psychiatric beds has decreased dramatically by 14% in recent years. Do you view that as one of the biggest barriers of care? Where do you sort of rank that in terms of ensuring that people get the care that they need?
Yeah, I mean, that's at the top of the list. I guess I haven't gone through the trouble of ranking all of the terrible problems that we have in our behavioral health system. That would be far too depressing. But yeah, that's at the top of the list because what's happening is that people are just sitting in emergency rooms for days and days and days. But there also then is created a pressure on the back end where by the people who are in the institutions are being pushed out before they're ready. And we just hear that story over and over again in Connecticut. A woman who's become very close to me tells a story about her son who committed suicide the day after discharge from the hospital, and she begged for him to stay. And not clear whether it was the hospital pushing him out to make room or the insurance company pushing him out because they didn't want to pay. But his mother knew he was not ready to come home, that he was not stabilized. But when you lost 4,000 beds since 2007, there's just only so many places that you can go. And listen, this is going to be the challenge. I mean, let's be honest about our two bills. Our two bills make two major changes. They get rid of the IMD exclusion, so you can start building inpatient capacity again, and then they allow for the same-day rule to go by the wayside. Those are going to cost money, and we have got to make the case to our colleagues that you cannot fix this problem if you resource it at the level that it is today. And in this budget environment, that's very, very difficult, but it's not going to be enough just to rearrange the deck chairs. You've got to actually make some serious investments. That's not going to be easy, but Tim and I and Bill and Eddie Bernice and the others working on this are committed to it.
I want to just make sure that it's time for audience questions, that people who haven't already asked a question get the opportunity to. So if you've already asked a question.
I never got to my question. You cut me off.
I'm sorry. I think we just need to make sure that there's new voices in the discussion.
My question. Murphy cut me off before I could ask my question.
Okay, very briefly, can you ask your question?
Yes, I may. I just am looking at the very first line of Murphy's Law or proposal, and you started talking about stigma as well, all right? And he quoted violence, 10% of untreated psychiatric disorders result in some sort of violence. And you're concerned about stigma. Well, here I quote the very first line in the summary.
Can you ask your question, please?
Untreated serious mental illness in recent acts of mass violence. So the very first line of that immediately connects violence with those who have a psychiatric diagnosis.
So yeah, I think I spoke to this, and very intentionally. I think this is amongst the most important questions we have is how do we acknowledge that we are talking about behavioral health reform in part because of these episodes of mass violence without perpetuating and creating this stigma. And so again, I've been very outspoken on this matter. We should fix our behavioral health system because it is broken, full stop. And it doesn't mean that we should forsake the opportunity to fix the behavioral health system, but it's very dangerous if we talk about this in the wrong way.
Thank you.
Not answering the question.
Go ahead.
How are you doing today? Can you hear me? My name's Jennifer Hoff. My son, Matthew. Thank you so much. I'm here from Orange County, California. I'm a family member of one of the 4%. And as a member of the 4%, our voices aren't generally shared because our family members are too sick to speak up for themselves. They're not well enough to find their way to a meeting here today to advocate against civil commitment reform out of fear-mongering because they think they're going to get locked up because they're homeless under a bridge. So they're too sick to advocate for themselves, so we have to come here to advocate for them. So my question would be, what are you doing to address the needs of the 4%, those who lack insight, like my son, who was institutionalized from ages 12 to 18 because he didn't respond to the current medical treatments? There was no brick walls for our family financially, nor in our Rolodex, but unfortunately, it's not brick walls we faced, it was cracks in the system by design. without restructuring SAMHSA, not eliminating and dissolving, but without restructuring, families like us don't see the money being spent differently. So simply increasing funding would not necessarily mean funding going in the right direction. Our families are not represented in data pools from SAMHSA. You will not find my son as a failure on anyone's pretty pie chart. My son has found his peer group now in state prison because that's where they all end up when they turn 18, graduate from their facility, get a plane ticket and their shoelaces, and go back home to our communities, upon which there are no wraparound services for people like my son because they choose not to participate in services because they're not sick. So the question is, how is your bill going to address the needs of the population upon which we don't even know how many exist because no one's tracking them until they wind up incarcerated? He walked into a bank pretending to be ISIS off his meds, demanding $1,000 or he'd blow the place up. He's serving 14 years in state prison.
Thank you.
Okay, he doesn't have meds. It's a known population. How are we addressing those voices? How are we representing those families? And how are we looking out for the families of the monster? The families of...
Thank you. I'm sorry. Thank you.
So it's a big question, right?
Basically, these tragedies are not a surprise from our vantage point.
Yeah.
They're not a surprise.
Yeah.
So, and we're not trying to connect violence to all mental illness. But I'm going to tell you right now, I've been screaming for 17 years for help. So it's a known population we're dealing with, and how are we dealing with
so
them?
let me try to. I know we got a long line here, so let me just try to answer it. One. You've got to empower parents and families to be more involved, and current HIPAA laws don't allow that, especially when your child becomes of majority age. You are all of a sudden cut out of the decision-making process, and so both of our bills include changes to HIPAA laws to allow parents to be more involved. Second, when I go around and talk to my behavioral health community, I ask one simple question. I say, for the really complex behaviorally kids, who's in charge? And everybody looks at each other. And nobody really has an answer, right? Some people say, well, the school, social worker's in charge. And some people say the primary care physician's in charge. And other people say the community health physician is in charge. We've got to answer that question. And my belief is that as you build these coordinated systems and you change the way that we pay for healthcare so that you're requiring systems to coordinate across each other and to get paid based on how healthy they keep people rather than how sick they keep people, they will solve some of those questions of leadership. And so, no, listen, the reason that Tim and I are doing this is for the people like your son, right? That's the reason that we've decided to dedicate our legislative lives to trying to fix this. And I'm sure we don't have all of the answers, probably not even 25% of the answers in this bill, but we're trying.
Thank you so much. Do we have another question?
Yes, Senator Murphy, my question is, if the IMD exclusion is lifted or partially lifted, probably effectively completely lifted, and the money will go, some of the money will go to state psychiatric hospitals, but there is is there a requirement that the states that then divert their Medicaid match to help pay for that hospitalization maintained funding for Medicaid services in the community mental health system? And because the state funding for mental health is only back to where it was before the recession.
Right. Most all of these expansions of federal dollars include a maintenance of effort provision. I will double check on that within our bill. That's certainly our intent, is to make sure that you're just not robbing Peter in order to pay Paul.
I'm not aware that's in your bill.
Yeah. Okay. Well, we'll be glad to take a look at that and follow up.
Do we have more questions on either side? No, I have just one more for you, Senator. I wanted to talk a little bit more about when you're talking about this issue of mental health, obviously there are a lot of stories and a lot of people who are very passionate about this. Do you find in your conversations that sort of mobilizes you, keeps you going, ensures that you can go to leadership and say, I think this is worthy of getting floor time? And are you optimistic that this bill will move forward out of committee?
So I think, to be honest, I think it goes both ways. So I think the reason why we've grown this very quick, robust, bipartisan list of support is because the issue is personal, because, I imagine that every single person that signed on to this bill is doing it in part because they intellectually understand the challenges that are confronted by the people in this audience, but they also have a personal story as well. But I'll be very candid with you. The deeper I get into this issue and the more time that I spend with families, the more complicated the solutions become to me. I started out by saying that my family just sort of thinks about behavioral health in the same way that we think about physical health. And that's the way that we have attacked the stigma, is to say that the two are identical. But they aren't. Mental illness is often wrapped up inside trauma in a way that complicates and compounds it. And it's got to challenge us to think differently about how you address the underlying issues. If you have a broken leg, you really can just put a cast on it and it'll be better. But if you have a complicated behavioral health illness, it may not be that you just need to treat that individual. You may also need to treat the support system around that individual. You may have to reach out to the parents of a child or the siblings and talk about some of the issues that have compounded the behavioral health issue by surrounding trauma. I remember going to our biggest inpatient psych unit for kids in Connecticut, and they had about 16 kids that day in the unit, and I asked the director, I said, well, how many of these kids also have trauma histories? And this is a behavioral health unit. And they said, well, he looked at me, he said, well, all 16 of them have trauma histories. And so I guess it certainly inspires me every time I hear a story to do better, but it's also made me understand that you are going to have to approach this new holistic system we're building in a slightly different way than you might approach a physical health or primary care system. You've got to challenge the system to have the resources to reach out and treat those around and help those around the individual, not just target the individual.
Congress is obviously working on this in a bipartisan way. Is the White House engaged on this issue? Have you been talking with them at all about sort of the prospects of a mental health bill?
The White House has been engaged. I would love for them to be more engaged, frankly. And so we've clearly been working with HHS and with SAMHSA on our proposal, as has Tim. I'm not sure yet who's going to be testifying at our hearing in the Health Committee later this month, but I imagine the administration will be there. Secretary Burwell is serious about this issue. Obviously, she is very, very bold in her reform proposals for how HHS and CMS reimburse for healthcare, and we just want to make sure that as they're building this new model of rewarding outcomes rather than rewarding volume, that they are also doing that for the behavioral health system, understanding that in the behavioral health system, there is frankly a greater connection between the volume of practice and the quality than there may be in other parts of the healthcare system. That really one of the things that we are lacking in the behavioral health arena is the volume, is just enough visits, is enough beds. And so we want to make sure that this payment delivery system reform is really thinking about the unique way in which it has to encompass the behavioral health system.
I want to thank you for all of your time, Senator. I really appreciate it. I think this was a productive conversation.
Thank you very much.
Thank you.
Please welcome Dr. Renee Binder, President of the American Psychiatric Association, Kathleen Nolan, Director of State and Policy Programs at the National Association of Medicaid Directors, John Snook, Executive Director of the Treatment Advocacy Center, Mary Giliberti, Executive Director of the National Alliance on Mental Illness, and Dr. Fred Osher, Director of Health Systems and Services Policy at the Council of State Governments Justice Center.
Good morning. I want to thank you all for joining us today, and I'm hoping that we sort of have a lively and exciting discussion here on stage. I've told the panelists, I hope you all kind of interact with each other. I have a couple of questions for you each individually, but please feel free to weigh in as we kind of talk about this. Obviously, there are a lot of perspectives and voices on this issue, and we want to make sure that they're all represented here. I want to start with Dr. Binder. I wanted to ask you to address this issue of parity. I think that this has come up a couple of times with both Senator and Congressman Murphy. And is there a better way to address this? What do you view as the way to ensure that insurers are being fair about the way they treat mental illness compared to physical ailments?
So parity for mental illness is the law right now, but unfortunately it is not always the case. And there needs to be better enforcement of parity. The problem is that the people who are not getting parity are often people who cannot advocate for themselves. And one of the things, for example, that the American Psychiatric Association is doing is we have developed educational materials, we have developed posters. We are asking every psychiatrist in every clinic to have this poster up in the clinic, and the poster says, you are entitled to coverage for your mental health care in the same way that you are entitled to coverage for your physical care. If you are not getting this coverage, then this is what you need to do. This is the number to call. This is how you take care of it. So we need to let people know what they can do when they don't have parity.
Okay.
Yeah,
go ahead, please.
NAMI did a report last year where we asked our members what they were experiencing with respect to parity, and they were finding that denials for medical necessity and mental health were twice as much as for physical health care. And the networks, we've heard a lot about that, were completely inadequate. People couldn't get access to care. And there's also a big concern about medications and having access to the full array of medications under these plans. So we found a lot of problems when we went out and talked to our members about parity enforcement.
And obviously this is a burden for someone who's already dealing with mental illness to be able to report issues of parity. It's bureaucratic, I assume, and difficult to get through.
Very.
I wanted to also ask John Snook, your organization, the Treatment Advocacy Center, focuses on eliminating barriers to mental health. What do you see as those biggest obstacles keeping individuals from getting the care they need in your experience?
Sure. I think one of the biggest, and you've heard it discussed already today, is just that idea that we haven't kept our treatment laws up with the science. And so we have a situation now where everybody in this room realizes that if you have a severe mental illness, and you're in treatment, you're no more likely to be dangerous than anyone else. But at the same time, we have treatment laws that say you can't get help unless you're a danger to yourself or someone else. So what that means is if you're a person who's ill, who needs care, you're left to your own devices until you get so sick you're actively violent to yourself or someone else. And that's not how we treat any other illness. And Murphy are really taking steps to say we need to change this.
I wanted to kind of going off of that, is there a way to intervene earlier, and what have you all seen in terms of successful programs that intervene much earlier?
I think there are any number of ways that we see working in the states, and that's one of the nice pieces of these bills, is they allow states to step in and take those sort of next steps to make sure that people get the care they need before they're a danger, before they're sick. And what the reality shows is that if you treat people before they're at this level of crisis, it's cheaper and people do recover.
Lauren, if I could add to that, I think coming from the Medicaid perspective, one of the things we're really working hard on is what we call integration of physical and behavioral health. And I think one of the opportunities that comes from that is being able to find people before they're in a crisis, to have regular sources of care that don't just consider your physical health outputs and your physical health status, but actually are better able to spot issues that may have behavioral health ramifications or symptoms. And so by bringing, the previous speaker talked about co-location, some of those ideas where you're trying to think about the whole person actually can do better at spotting things early than when we're only classifying you as needing a behavioral health when you're in that office and seeing those individual providers.
Yeah, go ahead.
Yeah, there are a lot of early intervention programs, and you're right, early intervention is very important. So there are programs in the states which target people, young people who might be developing early signs of schizophrenia. So an adolescent or a young adult whose thinking is maybe a little bit off, maybe they're not tracking information, maybe they have some unusual ideas. So they can be brought to a psychiatrist, and the psychiatrist will do a comprehensive evaluation to try and determine, are these early signs of psychosis and of schizophrenia? And if they are, there are very effective programs to get these young adults into treatment very, very quickly and to try and prevent full-blown schizophrenia. There are also programs in schools to try and identify children who have early problems. There's a program called Typical or Troubled, which targets teachers who are often the first people to notice. And so the teacher will wonder if is this typical behavior of an adolescent, or is this an early sign of some problems? And then they're not supposed to do the evaluation. They're not qualified to do the evaluation, but they identify it, and then they can refer the young person to a mental health professional, to a psychiatrist, to do a detailed evaluation and to say, does this young person need additional intervention? And maybe, hopefully, we can prevent future problems.
I also wanted to and wholly support the notion of prevention as a thrust of our community mental health systems. I wanted to just address the next step. We can't always tell or predict when an individual does have a mental health crisis, and that it really is incumbent on all of our communities to have a robust crisis urgent care capacity so that those people in need in the middle of the night, on a weekend, can easily access care that can help address their significant mental health symptoms at that point in time. Far too often, without those alternatives, we see the path of least resistance being to take that individual to a local county jail, which is not the place where people should be that don't pose a threat to public safety.
Yeah.
And I think Fred's exactly right. You have too many situations right now, and I think the IMD exclusion goes very far to fix that. In many communities, what you have is doctors triaging and saying, well, this person's sick and needs care, but he's probably not going to hurt anybody tonight, so we're sending him home because we need that bed for somebody who's even more ill. And that's just a terrible way to treat people. Imagine for your family. You've heard from families today. You're lost. You have no options to care for your loved one, and you're worried they're going to be the next headline. It's a terrible way to do things.
Dr. Osher, I also wanted to sort of piggyback upon that and discuss the issue of people with mental illness who end up in the criminal justice system. You've done extensive research on that. What can local law enforcement do better to understand that population, to preemptively work with them, or once people are in the system, create programs that make it easier or less traumatizing?
Yeah. So that nexus between behavioral health and criminal justice is one that is really important for us to explore. Just as I applaud the bipartisan approach that Senator Murphy and Representative Murphy have taken to the mental health reform issue, so too do we need collaboration across the behavioral health and criminal justice spectrum. With regards to law enforcement, we have about almost 2 million people each year with mental illness that are in our jails and our prisons, many of whom don't pose risk to public safety. What we have seen is law enforcement agencies around the country developing specialized police-based responses, the most common of which a crisis intervention team, in which those officers learn about mental illness, learn about how to de-escalate situations when they encounter them in the field, and then are given alternatives to incarceration for those individuals that can then seek that care. It's really an important component of an overall strategy to reduce the prevalence of mental illness within our jails, which are filled with individuals with mental illness, 4 to 8 times rates of mental illness in our general population. Every county around the country is struggling with this. A national initiative called Stepping Up, where Council of State Governments Justice Center and the American Psychiatric Association Foundation, National Association of Counties, NAMI, and other groups have come together to say, you know, the status quo isn't acceptable. There are things that we can do. There are interventions that we know work. We need to bring them to scale, and we need to drive the prevalence of people with mental illness in our jail settings down.
At NAMI, there have been a lot of programs, and you guys advocate for individuals. Do you find that they have access to the care, or that they even have knowledge that it exists? I mean, could there be more done to sort of expose programs that are out there? I mean, maybe that is one of the barriers of care.
Sure. I mean, we take thousands of helpline calls every year, and people don't know where to go for help. They often have no idea if there are crisis services in their communities. Most often they think that they have to choose between the police and no care. And so it's absolutely an issue of knowledge, but then there's the issue of there isn't sufficient service there. I can't tell you how many times I've tried to help families find help, and the help is not there. It's not covered by their insurance is a big problem that people experience. It's not available. Beds are not available. There's nowhere for people to go. So it's a knowledge problem, and then it's also an access problem. And we say we want people to have early, easy, effective access to care, effective being evidence-based. Lots of times you get care and there's no evidence that it's going to help you. We know what works, but people can't get it.
I want to address the issue of sort of rural communities and care versus urban centers, where maybe there are some more programs and resources available. What can we do for those individuals who don't live within 20, 30, even a couple of hours from mental health care centers?
Well, I can jump in here. Yeah. There's in the Medicaid space, I think there used to be a bias that the face-to-face was so important. And the only way to deliver these types of services. And we are increasingly in both the physical and the behavioral health space using more and more technology and supportive things. So telepsychiatry is something that a lot of rural communities are really trying to tap into and to be able to care for people in their communities. I think that's really the most important aspect that we have, and access in your communities, and then being able to continue your care in your communities. So we have a couple of things like telepsychiatry and telecounseling, but there's also the need not just to support the individual in their community, but the community providers who may not have the expertise to deal with those. So we have a couple of examples of states who are really trying to essentially Vermont uses a hub and spoke model where you have a center of excellence that may treat people in crisis or do some interventions, but then helps work with the community providers when that individual returns to the community. So those kinds of models that support the individual in their community and the providers in that community to care for them and to maintain their continuity is really important.
I want to ask, at Medicaid, sort of what do you see as maybe some of the shortcomings of the programs, and how can legislation help to sort of expand coverage?
So I think some of the shortcomings are, I'll set aside the issue of access, because if it isn't there to purchase, we as payers are really struggling. But there are some, I think the one that has come up the most frequently that is a barrier right now is the exclusion of IMDs. And I'll assume a general level of information in the community, in the audience here, about what that is, since it's come up a few times. But the issue that leaves for us is that there are sometimes a need to have these individuals in what would be called an institution for a short period of time, but we drop them out of the system of Medicaid. When we do that right now. With the IMD exclusion, we can't keep them in a continuity of care environment if they need admission to one of the IMD facilities. And so what's really important is we have to figure out a way to be able to include IMDs in our systems of care, but not to flip the switch. We are not looking to warehouse people and put them back in the hospital. But that exclusion of that facility type or some of those facilities from our continuity of care is really concerning and really a challenge to take care of people. So bottom line, the IMD exclusion is one of the biggest barriers for us in really getting to a stronger system of caring for people with behavioral health needs.
Thank you. We have all sort of talked about mental health courts. I want you all to sort of weigh in on what you've seen, whether they work, whether they need to be at a larger scale in order to be more effective. What have you all seen?
So mental health courts are very effective for appropriate patients. So the way that it works is that a person who has committed a crime and they have mental illness is approached by the public defender, and the public defender says, you have a choice right now. I'm your defense attorney, and I will defend you, but we know you did the crime, and we know you're going to stay in jail or go to prison, but you have an opportunity here. I can go to the DA, and I can try and make your case that you need mental health services, but you're going to have to participate in it, and we're going to have to go to the judge and say that this is appropriate for you. And the services involve medication, seeing your therapist, substance abuse treatment. It may involve housing. And if you are willing, we can keep you out of jail. And you will no longer be a defendant. We will change your title to a client right now. And it is very effective. I have done a couple of studies on behavioral health courts in San Francisco. And what it shows is that people who participate in mental health courts, in behavioral health courts, if you follow them over a period of time, if you compare them to similar kinds of people who have committed the same sorts of crimes, have the same mental illness, and do not participate in mental health court, there is a decreased incidence of violent crimes, and there is a decrease in jail time. So that is really an effective way of getting people out of the criminal justice system and into treatment.
Yeah.
And certainly I support mental health courts and specialty courts as a tool within our toolbox, and really appreciate Dr. Binder's work in this area. It is the case that they tend to be small in scope, and the number of clients and participants are relatively small. For those selected clients, it's a really important opportunity to get connected to care and move forward in their recovery. It also is an opportunity for the judiciary to learn more about the needs of defendants with mental illness. The smallness makes it a tool and not the solution. And then one other component of it, they are dependent on a effective, robust, accessible mental health system. And so at the very core, what we are talking about today is improving our behavioral health responses so that a variety of mechanisms that are well articulated and known can work effectively, including mental health courts.
And just to pick up on what Fred's saying, the Treatment Advocacy Center fully supports mental health courts, but I think we have to recognize that the existence of mental health courts is a recognition that the system has failed. Mental health system fails when we have to arrest someone for them to get treatment. So the programs like AOT, Assisted Outpatient Treatment, that we talked about a little bit earlier, is a mental health court without having to be arrested. And we're talking about states not using it, states having it on the books, but not doing the work they need to have it effectively implemented. And that's a systematic failure that I think Congressman Murphy touched on, that for too long we've allowed the system to just say, well, he's a difficult patient, he's going to be a lot of work, he's going to be expensive, we'll let him go and the jails will take care of him. And that's a failure.
I just want to remind the audience we have about 2 minutes until questions, so feel free to line up. Obviously, a lot of voices and expertise here to discuss these issues. I want to talk just about not just access to care, but are there enough doctors? Are there enough trained professionals to deal with clients? That's part of the barrier to care. Can any of you sort of address that?
So as a psychiatrist, I can say that there are not enough psychiatrists. There is a workforce issue, especially when we talk about child and adolescent psychiatrists, where there are even more problems. Now, in these bills that have been introduced in Congress, which the American Psychiatric Association supports, there are solutions in terms of increasing the workforce, and it's absolutely necessary. Now, we may never have enough psychiatrists, and that's where we get into the kinds of programs such as telepsychiatry. So if a psychiatrist may not be available in that particular community, you can see them, they can do an evaluation over long distances in integrated care clinics in rural areas for patients who are disabled or elderly and they can't come to the psychiatrist's office.
Okay. I think one of the biggest challenges for Medicaid is when there's a shortage, we have the hardest time competing for those providers. We frequently don't pay as much. We acknowledge that. We often have people who could be considered, as you said, more difficult to deal with. They don't come in. So we have a very hard time when there is a shortage. It doubles down on our most vulnerable people who need those services the most. So even when there is a psychiatrist available in the area, we often have a hard time making space for Medicaid patients to see them.
Yeah, families call that Medicaid card a license to hunt.
Really? Yeah.
Meaning you have to hunt for care. You can't find it.
It's really
the reimbursement for Medicaid is very low. In my community, I live and practice in San Francisco. The psychiatrists say that for patients who are Medicaid, it costs them more to provide the service than the reimbursement, and something needs to be done about that if we expect psychiatrists and other healthcare providers to see Medicaid patients.
I want to start with questions. We'll start over to the left. You can feel free to address questions to individuals or just throw it out to the general panel.
Great. My name's Laura Truman. I work for House Majority Whip Steve Scalise. We just became a co-sponsor of Mr. Murphy's bill. So very excited about that and feel like that helps on the front end to be able to get people into care so they don't commit crimes and end up in jail. But the criminal justice reform that's going on right now, all the discussion presents a really great opportunity for us to do something on this. And having reviewed a number of the bills, I don't think we're quite doing enough. We have things like, studies and things that would encourage more mental health courts. But I'm not sure there's a big enough carrot or stick there that would address what happened last week with the young man in Virginia, et cetera. Would you all have ideas respecting federalism to some degree, not bigfooting totally, but doing better than we are with some of the proposals, on how we can encourage states to prioritize making sure that these folks don't end up in jail?
Well, a very important topic. Thank you very much for the work you do. As I mentioned earlier, this is an area, criminal justice reform, where there is bipartisan conversations going on right now. And it's very heartening to see those conversations as we think about the relative role of our jail and prison systems as they play in keeping our communities safe. I would highlight a bill that's also in Congress now, the Comprehensive Justice and Mental Health Collaboration Act, which does fund along a continuum the type of services and interventions that have been associated with assisting individuals with mental illness stay out and avoid involvement with the criminal justice system. So that is also bipartisan with the support that's there. Senator Franken and Cornyn introduced the bill, and that it really is an important, I think, federal incentive for communities around the country to develop these effective responses.
Thank you. Seeing no questions on this side, we'll go back to the left.
My name is Bernie Ahrens. I'm a psychiatrist. I'm a medical director of a large psychiatric hospital. I used to work in SAMHSA. I'm thinking about the two speakers we heard earlier and this panel, and trying to crosswalk between efforts at federal legislation and the work that advocates and mental health professionals do. You've raised some very important areas that need attention: crisis intervention teams, criminal justice diversion programs, mental health services in jails and prisons, opportunities for expansion and training of the mental health workforce. And I'm wondering whether the attention to federal legislation helps accelerate the implementation of those programs, or diverts our attention in a way that may prolong that. I wonder, for example, if attention to how the bureaucratic boxes are structured in the federal government is where efforts should be spent or somewhere else. So I'd be interested in your thoughts on whether you find the federal legislation helpful in the advocacy and professional work you do, or a diversion in some ways that we need to be worried about.
Thank you.
I think I can tell you pretty clearly that having a senator not only know what IMD stands for, but talk about it on a stage is amazing. To have Congressman Murphy go county to county talking about fixing SAMHSA and fixing the mental health system is amazing. I think we have never had as an exciting time as we have right now. This momentum to finally reform the mental health system. If this is a problem, I'd love to have more of them.
And I just want to add that I think that the efforts are complementary. I mean, you mentioned CIT, there's federal bills to add some resources there, but we also work at the state level at NAMI trying to get statewide technical assistance around those programs to build them up. I think the federal attention only complements what we're trying to do at the state level as well and provide some resources that can serve as a catalyst to that. So I see the efforts both locally and at the state level and nationally as complementary. Fred mentioned the Stepping Up campaign. That's really focused at a county level, at a local level. But the work that we're doing on Capitol Hill, we held a briefing on Capitol Hill to talk about that effort. I think they're very complementary.
I think we also heard, a number of examples that come from the state level. There is some innovation, and that's how our country works. We innovate at the state and local level, and we learn from that at the federal level, and we reinvest the dollars where it can best work. So I think that whatever the federal structure, we have to keep that living. It can't be a single solution, because I think that it does come out in different ways, and there's different types of things that work in different communities, rural or urban, or places where there's different kinds of challenges or opportunities. So I think that as we continue the conversation at the federal level, which is vital from the resource perspective and from the regulatory framework perspective, we have to continue to find those great examples at the state and local level and share them to drive that innovation.
Yeah, this is an incredible moment in history, if we think about it, to have the support of Republicans and Democrats, to have a bill in the House of Representatives and a bill in the Senate, and for people being motivated to work together on both sides of the aisle to really do something and to highlight the fact that our current system is broken and that we can fix it. We can fix it federally, and we can fix it at the state level. So I'm very excited about this.
Thank you. We'll take a question from this side of the room. Thank you.
I work on the Senate Help Committee, and I know we talked a little bit before about early intervention. If you could talk more to that, about early screenings, maybe children in school or through the pediatrician's office be doing that, a little bit more about what those kind of screenings may look like.
Thank you.
I can jump. Do you want to go ahead?
No, you can go.
Okay. I was just going to say we are seeing those kinds of innovations in Medicaid. It takes a little bit of a switch in thinking, because you're not diagnosing something. You're diagnosing something that may happen. So it's a change to our system and how we think about getting people into different programs. But we are seeing that kind of focus. But it's a challenge, and so I think we need to be thinking about how do we put people into some of these programs. I also know a lot when we talk about children or young adults, the classification is a concern. And when you move that into giving them labels, we really have to be cautious about how we do this. And when we're doing it in a healthcare system, that information will travel with that person. So it's just something where it's a dynamic I think we're working on, but it is happening.
Thank you.
I just want to add that I think some of the work that NIMH is doing, which I know the Help Committee is very supportive of for young adults who are early experiencing psychosis, is so important. The way that approach is very different. It approaches people with what do you want to accomplish in your life, and how do we support that through supported employment, supported education, as well as the treatment, the medication, and the therapy, and includes families. And one of the issues is, are we going to be able to finance that going forward, financing it with Medicaid, financing it with private insurance dollars, because it's such a wonderful approach for people who are first experiencing these issues. I had the privilege to go to one of these programs, And it's very different than a regular mental health center. You walk in and I saw a ping pong table and the young adults were cooking and they were laughing, and had a very different feel to it. And I think that's why it's been so successful. And I know NIMH is going to be coming out with their data soon on that. But I think that's a really important program for people to focus on, because it would be a great disservice if it didn't spread, so that anybody who's encountering what's a very serious chronic condition of the young has access to all of that service.
Thank you so much. I'll take one more question.
Very quickly, my son died this year at age 23 of heart failure after a 7-year battle with schizophrenia. I'm the director of Parents for Care in Baltimore, Maryland. I get phone calls every week, desperate emails every week. I can't get my child care, right? We all know that parity is really the issue, and I would say illegal discrimination, or rather legal discrimination rather than stigma. What I want to know is, and parents mention this to me all the time, and I used to mention it to Johns Hopkins during treatment. Insurance won't keep my child in the hospital. Why don't we sue them? Why don't we sue for medical parity? What are your thoughts on that? No one, I can't think of a lawsuit. I think the state of California right now has one going to force parity. What are your thoughts on that?
Well, I totally agree with you. And the American Psychiatric Association is actually involved with the lawsuit in California, and there is a lawsuit in New York. And bringing lawsuits can be very, very effective. I'm really sorry to hear about you. I think you raise another good point about the comorbidity of medical illness and of psychiatric illness. It's another reason for co-locating services together. So when someone comes in for some cardiac problems, they can also have mental health screening. And certainly when someone comes in for mental health problems, it's not just a problem of the mind. There are all kinds of associated physical issues, and a person is the whole person, and we need to take care of the whole mind and the whole body and the whole brain.
And these sort of events are so vital, because I think if you talked to a person on the street, they would have no idea about things like same-day billing, about the idea that you're not able to get physical care the same day you get mental health care. Any of these issues we're talking about, it's just simply not on people's radars. So the more we can talk about the realities of what you deal with, you hear so often, well, why didn't the family just get him help? Having no idea that families have no options, and we need more solutions. And this is the best way to do it, to bring those issues up and to have these discussions.
We sue for everything else.
Thank you so much. I want to thank our panel for their insights and help. I really appreciate it. Thank you so much.
Thank you, Lauren.
Please welcome back Johanna Derlega, Senior Vice President of National Journal.
Thank you so much to Lauren and to our panelists and speakers today. A very special thanks to Janssen Pharmaceuticals. At this time, I would like to invite Michelle Goodrich, Central Nervous System President at Janssen Pharmaceuticals, to the podium for closing remarks.
I just want to thank everyone here for their amazing engagement and participation in the discussion today. A special thanks to all of our speakers for a very thought-provoking discussion. And a special thanks to our audience members who shared some very courageous stories. Thank you for doing so. Janssen is very pleased and proud to be part of this, what we consider is a very important conversation, and to help continuing championing better solutions for people with serious mental illness on their path to recovery. And Janssen's had an unwavering commitment to delivering innovative medicines in mental health that spans over 50 years. Our organization remains at the forefront of advancing central nervous system treatments and improving care for people with brain disorders. And we will continue to invest in finding innovative treatments and developing solutions that improve patient outcomes. So at the same time, we do recognize that pharmacological treatments are but just one element of putting people with severe mental illness on their path to recovery within the larger ecosystem of patient care. So the legislative and community-based solutions we've been discussing today, we think are critical to ensuring that individuals with mental illness are supported and they get the best chance they deserve to hold meaningful lives. So early diagnosis and intervention from the medical and mental health community are particularly important and may result in better health outcomes, reduced costs to those with mental illness, their families, and to our broader society. So as you've heard today, the collaboration between the mental health and the criminal justice systems we think is critical to improving lives and reducing costs for both patients and public systems. We really applaud and thank and support legislative efforts to reform our mental health system. And together, we do believe we can find the best and most collaborative solutions that create a win-win for all. So thank you again for being here today and for being part of this very important conversation.